Good morning. Ooh, we can do better. Good morning. Thank you all so much for being here and welcome to the second annual CMS Health Equity Conference. My name is Dr. Aditi Mallick. I'm an Indian American woman wearing a navy blue blazer and a navy blue dress with silver shoes. I very recently had the pleasure of serving as the acting director for the CMS Office of Minority Health for roughly the last year, and I am so glad to be with you all over the next 2 days. On behalf of the Centers for Medicare and Medicaid Services, I'd like to thank you for joining us today and tomorrow as we highlight some of the really exciting health equity work happening across the country, really in every corner of our nation. There is a movement and momentum happening in health equity, and you can feel it in this room and see it happening virtually with all of you joining us. Last year was our first Health Equity Conference, and we really had to speak to the fact that it takes all of us to advance health equity. Well, you all have made that very, very clear. We received over 600 proposals from people looking to speak at this conference. 600 examples of health equity happening everywhere in every part of the health system, in every corner of the country, and really amazing proposals. We were overwhelmed, humbled, delighted to hear about all of your work. We at CMS really make a point of hearing from our stakeholders throughout the year, here at this conference and all year long. As you heard in the video that preceded my remarks, we heard from Kevin and Pilar, who are enrolled in Medicaid and the Marketplace, respectively, about the importance of good healthcare coverage and health care to lead a full life. Eugene expressed the relief of having covered services when he began as a Medicare enrollee. And Angel spoke to us about his experiences in being able to impact society through his experience with Medicaid. These are real people with real health needs who have experienced disparities but are committed to living their best and healthiest lives and helping all of us understand how to be a part of that journey for them. We are driven by their voices and by those voices of people in our programs and contributing to that journey of health equity. At our conference this year, we'll hear from 62 sessions, and these are the ones that not just had wonderful work to share, but really spoke to this year's conference theme of sustaining health equity through action. Many of those conference sessions were filled by community organizations, providers, health plans, and others working directly with people to implement health equity solutions on a long-term basis. We've been listening to our partners, providers, consumers, community advocates, and people who want to know what's happening, what's working, what can they replicate? What can they keep moving? What can they bring to their local communities? And sustaining health equity really takes long-term effort, but we need action. We need action to see health equity realized in the long term. And it's that long-term planning that makes me so excited for what I get to share with you today. As I noted earlier, I've had the pleasure of serving as the acting director for the CMS Office of Minority Health for the last year. But we now have a permanent director for the office. He's here today. It has been my sincere privilege to serve in the role of director in the interim. Health equity has been a personal and professional priority for me for a long time. And I know our new director feels the same way and will work every day to advance OMH's mission to achieve health equity. So it is my pleasure to introduce Dr. Martin Mendoza, the new director of the CMS Office of Minority Health. Dr. Mendoza comes to us from the National Institutes of Health, where he most recently served as the Director of Health Equity for the NIH All of Us research program. Dr. Mendoza has worked across HHS, including serving as Director of the Divisions of Policy and Data in the HHS Office of Minority Health and leading minority health policy efforts in the Office of the Commissioner at the FDA. Dr. Mendoza is also a proud Marylander. He's a graduate of the University of Maryland, Baltimore County, and received his doctorate in cancer biology from Johns Hopkins University. Please join me in welcoming Dr. Mendoza to CMS and to the stage.
Just a minute, Dr. Mallick. Don't go anywhere just yet. Come back over here, please. So good morning, everyone, and thank you, Dr. Mallick, for that warm introduction. I cannot thank you enough for your continued service and dedication to CMS and OMH. You are such an amazing, strong, caring leader with there's a super clear focus and devotion to health equity. Your insights, your experience, your strategic visioning have served the office and CMS so well, and absolutely plan to continue to build upon all that great work you are currently leading. I just cannot simply say thank you enough for your partnership in this transition. And so we just have a small token of our appreciation, one of many, but we just wanted to share this with you. And so please, another round of applause for Dr. Mallick and her continued service to CMS. I also want to take a moment to acknowledge and thank previous CMS OMH Director, Dr. LaShawn McKeever, who unfortunately could not be with us here today, but it was Dr. McKeever who had the vision for beginning this conference last year, and so I want to take a moment to acknowledge her and her leadership. So wow, what a start to week 2 of my tenure here at CMS. There really are no words to describe just how thrilled I am to serve in this new role as CMS Chief Health Equity Officer and Director of CMS OMH. As you heard Dr. Mallick mention, I'm a longtime Fed, having worked across various HHS agencies to advance health equity. I'm so excited to join CMS and the Office of Minority Health in its mission to tackle health disparities. So I come from a background of research where I saw the importance of clinical trial diversity, data, inclusion, and precision medicine in healthcare. And to me, it's innovation and access that really drive the healthcare system. And on a more personal note, to share my why, having lost my mother and all 4 of my grandparents to health disparities, and having diabetes continue to ravage so much of my extended family, this work is so deeply personal to me, as I know it is to each of you. And it is because of these reasons and more, it is why I believe it is our job, all of us here, to ensure health equity is considered in every corner of innovation and access. So over the next 2 days, you'll hear from CMS and experts across the healthcare system about the importance of innovation, access, quality, and affordability, especially for underrepresented and underserved communities that we are all so passionate about. So there's a lot of excitement in health equity, and we are here today to harness that energy to move us forward. So this year's theme speaks to the movement of health equity. We see health equity everywhere: our advocates, health systems, providers, and the federal government. And more specifically, we have examples of health equity happening across HHS and CMS programs that you'll learn more about throughout the next 2 days. It is absolutely my firm belief that we all need to continue working together to keep this forward momentum going, and that is certainly showing in your work, the proposals we have received, and in the real actionable examples you will see and hear about throughout this conference. And so I'm just so thrilled for CMS and OMH to be a part of the sustainability in this action. And so in addition to myself and Dr. Mallick and our teams, we're joined by leadership from CMS as well. So you'll see many of these leaders from our agency over the next 2 days, people focused on Medicare, Medicaid, innovation, quality, and more. And also at this conference are folks working in billing, seeing patients, enrolling people in coverage, helping people get services, researchers, students, government workers from CMS, HHS, states, territories, tribes, the list goes on. And that's so important because it takes everyone across all these different domains and all of us approach to really eliminate health disparities. But there's another person here at CMS who is just as committed to health equity as myself and Dr. Mallick and our teams. And it's time to introduce her and hear more about her unwavering commitment to health equity, including the important topic of maternal health equity. And so I have the pleasure of introducing our next speaker, CMS Administrator Chiquita Brooks-LaSure. So Administrator Brooks-LaSure serves as the 16th administrator for the Centers for Medicare and Medicaid Services, where she oversees programs including Medicare, Medicaid, the Children's Health Insurance Program, CHIP, and the Affordable Care Act, health insurance marketplaces. A former policy official who played a key role in guiding the ACA through passage and implementation, Administrator Brooks-LaSure has decades of experience in the federal government, on Capitol Hill, and in the private sector. Please help me welcome to the stage OMH's biggest champion and a true health equity leader, CMS Administrator Chiquita Brooks-LaSure.
Okay.
Good morning, everyone. I am so excited to be here. Thank you for joining us. This turnout is amazing. I am truly grateful for your continued partnership in our mission to deliver better health and healthcare for all people, no matter what they look like or where they live or how much money they have. It really means a great deal to all of us at CMS to see you here for our second annual Health Equity Conference. It just shows how much of your incredible commitment to helping the people we serve and making a meaningful difference in their lives. I want to take a moment to welcome Dr. Mendoza to CMS. We are so excited to have you on the team. I also want to thank Dr. Mallick for her leadership and agility over the past 10 months as acting director and in previous roles here at CMS. As I hope you have heard me say, it is an honor and a privilege to serve as a CMS administrator. And one of the reasons why it is because we have such an incredible group of senior leaders who are so devoted to mission. Since last year's inaugural Health Equity Conference, we've made immense strides in expanding access to coverage and making sure that coverage is meaningful to the people we serve. I would like to highlight a few of our accomplishments. First, we have covered more people than ever. Getting enrolled is a critical first step to getting connected to high-quality, affordable, preventive services and treatment for chronic illnesses, and the peace of mind that coverage brings. It is necessary, not sufficient, for us to achieve health equity to get people enrolled in coverage. Thanks to the Affordable Care Act, which turned 14 this year, we now have over 100 million people that are enrolled in Medicaid and CHIP and the health insurance marketplaces. That includes a record-breaking over 21 million people who selected coverage through healthcare.gov during open enrollment and the state-based marketplaces. It also includes people in South Dakota and North Carolina who were newly eligible for Medicaid, thanks to expansions in those states in the past year. That brings us to a grand total of 40 states plus DC that have expanded Medicaid. And as I have said before, when having the privilege of talking to advocates and stakeholders in the 4 states that have expanded Medicaid since the Biden-Harris administration took office, it has been so much of the work of advocates, of providers, of stakeholders, whether getting Medicaid on the ballot or working with their governors and state legislatures that got us over the finish line, and we won't stop until we get everybody coverage. With so many people relying on us for their healthcare needs, we're deeply committed to ensuring that their coverage is more than a card in the wallet. It must consistently connect them to our high-quality care that makes a positive impact on their lives. Our 2 new Medicaid and CHIP final rules, which we just released last month, made huge strides towards that ambitious goal. For example, we're strengthening home and community-based services, empowering people to live at home while receiving skilled care. Medicaid should meet people where they are, whether it's in a facility or in their homes. People with Medicaid should be able to count on getting high-quality care that they need and deserve. And for the first time ever, people with Medicaid health plans can count on getting an appointment with their doctor without waiting several weeks or months. The final Medicaid managed care rule requires all states to establish maximum wait times, not exceeding 10 to 15 days to see a primary care, maternity care, or behavioral health provider. We're also strengthening our support of the people we serve and the people who provide that care. The final Medicaid rules advance pay equity for direct care workers. They also create beneficiary advisory committees, official channels that give voice to enrollees, families, and caregivers. The Medicaid access and managed care rules represent many firsts in healthcare, and I'm incredibly proud of that. I'm also incredibly proud of our groundbreaking work to make prescription drugs affordable for people with Medicare. The United States has the most innovative treatments in the world, but that's only meaningful if people have access to them. As CMS Administrator, I hear firsthand from people that we serve about how they struggle to afford the prescriptions they need to stay healthy. For example, I met a woman from Pennsylvania who had leukemia. She told me she was running out of ways to pay for her treatment, one drug which cost $12,000 a year. For her, that was 13% of her gross income. Last year, I talked to a couple in North Carolina whose out-of-pocket drug costs were over $18,000 a year. That's more than the average mortgage in North Carolina. They told me how these overwhelming costs meant the wife couldn't retire. The Inflation Reduction Act is transforming healthcare as we know it, changing the outcomes of these stories. Starting this year, for the first time ever, people with Medicare drug coverage who have very high drug costs will have a cap on their out-of-pocket costs. For people taking high-cost drugs, like the 10 that were selected for the first round of price negotiation, this new cap on costs will deliver meaningful savings this year. I've already started to hear from people who have hit that cap already, and so they're no longer paying anything out of pocket for their prescription drug costs. And next year, everyone with Medicare drug coverage will have a $2,000 cap on out-of-pocket costs. We're already lowering costs for millions of Americans with Medicare through free recommended vaccines by the CDC, monthly caps on insulin costs, and expanded financial assistance. We're also working to expand access to innovative drugs, including the new cell and gene therapy model, in which we are partnering with states and drug manufacturers to increase access to gene therapies to treat sickle cell disease. For many people living with sickle cell disease, the majority of whom are Black, potentially life-saving treatments, like groundbreaking gene therapies, are unaffordable and out of reach. The cell and gene therapy model will help them access transformative therapies and potentially avoid health issues, like episodes of excruciating pain that are common to people with sickle cell disease. We're also aiming to help the Medicaid programs that people rely on. And in Medicare overall, we have taken bold steps and continue to work to embed health equity across our payment rules through new services, coding and payment changes, and quality measurements related to health equity. These are just a few examples of some of the bold actions that we've taken over the last year to advance equity and bridge disparities to healthcare. We've made huge strides. but not any of this could be made possible without you. Your ongoing partnership is essential to our success. It is our role and our goal to make sure that we are incorporating the experience of our partners and that we are listening and incorporating that into the way that we operate. And we thank you for being our partners in this effort. Thank you and enjoy the conference.
Thank you all for giving us a moment as we now transition to our maternal health panel. At last year's conference, I had the pleasure of joining a CMS-focused maternal health panel. Maternal health is a topic of tremendous personal and professional interest for me, for our administrator, for HHS, and I know for many of you. As you know, the United States is facing a maternal health crisis, and the Biden-Harris administration is committed to reducing this country's maternal morbidity and mortality rates, reducing the alarming disparities in maternal health outcomes, and improving patient experiences within the full spectrum of maternity care. The White House blueprint for addressing the maternal health crisis provides a whole-of-government plan to combat maternal mortality and morbidity and reduce racial disparities nationwide. The disparities seen in maternal health are heartbreaking, and we must collectively work together for real, lasting improvements. And HHS and CMS are committed to doing just that. I'm grateful to many of you, our maternal health partners, providers, advocates, health plans, advocacy organizations, and others for your tireless and innovative approaches that support pregnant and postpartum individuals for an optimal birthing experience. Thanks to the American Rescue Plan Act signed by President Biden, state Medicaid and CHIP agencies now have the option to extend postpartum coverage from just 60 days to a full 365 days after pregnancy. As of earlier this month, CMS approved Nevada as the 46th state, alongside the District of Columbia and the U.S. Virgin Islands, to now provide access to this life-saving and life-changing 12 months of Medicaid and CHIP coverage following pregnancy, an important lifeline for individuals, families, and communities. CMS is also proudly working on an innovation center model called the Transforming Maternal Health, or TMA model, which will support participating state Medicaid agencies in developing a whole-person approach to pregnancy, childbirth, and postpartum care. TMA's goal is to reduce disparities in access and treatment and improve outcomes and experiences for families and their infants. CMS is also committed to quality improvement efforts through the Birthing Friendly designation, which identifies hospitals and health systems nationwide that are participating in statewide or national perinatal quality improvement collaboration programs and are taking efforts to implement quality improvement best practices. There are concerted efforts happening across HHS to address this crisis, and we are joined today by three phenomenal leaders from the U.S. Department of Health and Human Services to showcase some of the maternal health work happening across the department. Please join me in welcoming to the stage CMS Administrator Chiquita Brooks-LaSure, the Administrator for the Health Resources and Service Administration, or HRSA, Carole Johnson, and the Assistant Secretary for Mental Health and Substance Use, and the Administrator of the Substance Use and Mental Health Services Administration, or SAMHSA, Dr. Miriam Delphin-Rittmon. We all agreed backstage. Can you hear me? Okay. we all agreed backstage we'd call each other by our first names, in case you're wondering. Let's set the stage to start, and learn a little bit about what's happening at each agency. I'll go down the line and ask each of you the same question. If you could spend a few minutes highlighting for the audience some of the maternal health work happening in your agency. Miriam, I'll start with you.
Yeah, so, I first want to say it is just such a pleasure to be here and to be with my colleagues. It's wonderful when we could be in person. We're on meetings like all week long, and it's wonderful when we can see each other in person. There is, quite a bit of work happening. And I have to say, I'm just so grateful that mental health is being incorporated into the maternal health conversation. We do find that sometimes it's overlooked. And so this space and this conversation is so important. And this is such a priority within SAMHSA, but really across the administration as well. So in terms of some of the work, one thing I'm really excited about is that we have in September 2023, a maternal mental health task force was convened, and it's a task force comprised of people across government, also outside of government, and the goal was really to come together and to develop strategies, priorities, and really to work to address the maternal mental health crisis. We know that when we look at data, we see about 22% of the maternal of deaths overall. Among individuals that are pregnant and postpartum, about 22% of those are related to sort of mental health or substance use-related challenges and needs. So the goal of the task force was to come together and put together strategies to address this. The task force, they got in the zone and they stayed in the zone because in just a few short months, they were able to develop the national strategy for maternal mental health care. And thankfully, we released that last week. We were really excited to be able to release that last week. And the strategy itself, it was developed with an equity lens. And so equity is a backdrop of every strategy, each area within that. It was developed with an eye towards equity. But it also includes a range of recommendations and strategies around early intervention, around prevention, around strategies for connecting women to needed services and supports, ultimately to be able to help and mitigate some of the patterns and trends we're seeing. So we're excited about that work, and ultimately we see that as a breathing document. We'll work to update that regularly as we see different patterns and trends changing over time. But in addition to that national strategy and the task force, I co-chair the task force along with Admiral Levine, so the Assistant Secretary for Health. And so there's a whole area of work happening there with that infrastructure. But SAMHSA also has been sort of steeped in this work for quite a bit. And we have, for example, I'll just mention a couple of grants. So we have our pregnant and postpartum women residential program grant for women struggling with substance use disorders. And we recently expanded that for women struggling with substance use disorders who are pregnant and postpartum on an outpatient basis so that they can continue to have their children with them. And that grant it's just such an important community-based resource for women and families and children to help women achieve and sustain recovery as they're going through postpartum or other, mental health or substance use-related challenges. And I'll stop there. There are other grants that we have as well, but I don't want to monopolize. So,
thank you, Miriam. Such important work, Carole.
Great. Thanks, Aditi. And thank you all for being here today and to creating this opportunity for me to spend time with my colleagues, which I love so much. If you'll indulge me, I'll just make two comments at the top. One, I'm really bummed I didn't text Aditi last night because I would have worn my silver shoes. They're under my desk. And two, all flowers to CMS. I mean, I have been in health policy long enough to remember the days when CMS basically paid bills and listened to insurance companies and listened to and the idea that CMS is hosting a health equity conference is a testament to the leadership. I mean, Chiquita and Aditi, and you'll see all day today the change that has happened, and CMS is in the game with us now. CMS has our back as we do this work. As Aditi mentioned, I'm the administrator of the Health Resources and Services Administration. Many of you know us. For those that don't, we are the part of the Department of Health and Human Services that focuses on delivering healthcare in historically underserved communities, supporting the workforce that makes that possible, working in rural communities to get access to care, supporting people with HIV, really focusing on what it takes to get healthcare to communities that need it. And as Chiquita mentioned earlier, and I'm sure she will talk about, incredible work has happened at CMS to expand access to coverage. But also, as she alluded to, your insurance card is only as good as having a high-quality place to use it. And that's where we come in. We at HRSA fund community health centers across the country, which see people regardless of their ability to pay. We are the backbone of maternal and child health services in every state in the country. We touch every newborn across the country. We are focused and laser focused on these issues. And the huge advantage we have now, like many of you in this room, I imagine feel the same way. You've been doing this work for a long time, but the Biden-Harris administration now has your back and is putting money and policy behind it. So just briefly, I'll tell you a little bit about what that means for us at HRSA, but how we're doing it in a collaborative way across agencies. First, we all know 80% of maternal mortality is preventable. That doesn't mean we wag our fingers at pregnant women and tell them to do things differently. That means we change the system that wraps around them so we support them better, so we do things differently. And for us, that has meant, one, the leading cause of maternal mortality is mental health and substance use, as Miriam said. We launched the Maternal Mental Health Hotline, 833-TLC-MAMA, 24/7, text or call, English, Spanish, translated into 60 additional languages, a safe space to have a conversation about maternal depression, anxiety, people who feel overwhelmed. We have not had a lot of marketing money, and in the short time we've had it launched, we've had more than 30,000 calls to the line. There's clearly a need here. Family members are calling, new moms are calling, pregnant women are calling. We want to be there and be that support for them. We also wrap that around with our maternal depression state-based program, where we're helping OBs, midwives, doulas get mental health training and then connect them to teleconsultation services. So if a pregnant woman is in their office and they know they can help them with a mental health need, if they can get a psychiatrist on the line, they can do that in real time. Two, while mental health and substance use are the leading cause of maternal death, it's actually cardiovascular issues that are the leading cause of Black maternal death. And that is why primary care is so important. And that's why we've really doubled down on our investments in expanding access to prenatal care and innovative maternal services through community health centers. And as I talk to our health centers around the country, one of the things that they've really embraced that has stuck with me is, for a long time, we have built out a care team and we have had community health workers as part of the care team. But now we're able in some of our health centers to assign a community health worker to a new pregnant person to be able to help them along the way. You all know it's hard to take time off work if you're making an hourly salary. It's hard to find childcare for your kids. It's hard to take 2 buses to a prenatal visit. We need to make that as seamless as possible, and we're working to do that through our health center work. But 3, look, everyone in this room has known this point longer than any of us. It is not just about what happens in the clinic. It's about what happens in the community. And that's why we're supporting, in the Biden-Harris administration, we've doubled the federal investment in home visiting. So nurses, social workers, parents as teachers can be in your home and help you in those early days up until preschool to be able to provide support. That's why just last week, it was 2 weeks ago, we did a $100 million investment in Healthy Start, which is our way to support community-based organizations. So much of what we are able to do at the federal level is fund the state, who then funds people. This is our way to fund directly community-based organizations in communities across the country. And what Healthy Start functionally is someone at the other end of the phone line. I just had to pay my light bill. I don't have enough money for diapers. I can't get to this prenatal visit. Can someone get me a ride? That's what we fund in community across community as part of our Healthy Start initiative. I'll just say 2 final things. We also know, and you know this acutely, that it takes a workforce to deliver this. And so we invest in training the next generation of the workforce, OBs, midwives, doulas, community health workers, peer support counselors for mental health services. That's part essential for who we are and what we're doing. And then thanks to the leadership in Congress, you all have seen talk of the Momnibus, that they're continuing to work on that comprehensive initiative, but we've gotten pieces of that funded. And so we launched with Morgan State University our Historically Black College Research Network to really focus on continuing to drive the what's next. Where can the evidence take us for what we should be funding going forward? So I really look forward to the conversation. Thank you again for the chance to be here.
Thank you, Carole. Chiquita.
Well, as you can see, this is an area that the 3 of us are incredibly passionate about. And I want to start by really giving credit to the Vice President, who has led a whole of government approach to addressing the maternal health crisis. And I think her efforts to really pull all of us together to really look and say, what are all of our levers across the administration to try to address the maternal health crisis has been incredibly important. And certainly we at HHS have an outsized role in trying to address maternal health. I want to start by talking a little bit about, again, just, necessary but not sufficient of trying to get people covered. We are so excited that we now have 46 states that have expanded coverage postpartum. It is an exciting development. Again, we really want people to have coverage throughout their lives because, as we know, some of our disparities are the result of people not getting health care before they even think about having a baby. But postpartum coverage, I think, is one area where, we know so many women that have not just death, but just have increased morbidity. And for all of you who are moms, I know that 2 months after you have given birth, you are trying to figure out so many things in your life. And to try to have to figure out, how do I enroll in new insurance? That's the last thing that we want any parent thinking about. And so it's so important that we make sure that people have coverage, but particularly parents have coverage after they've given birth, so they can really focus on making sure that they are getting the care they need and their child is getting the care that they need. We also have so many states who are trying to think of initiatives. You heard me just mention in our rules that we've expanded the requirements for states for maternity care. But one of the things that I am the most excited about is our birthing-friendly designation. And the reason why I'm so excited about it is because we are using the chassis of the Medicare program. The Medicare program does not pay for that many births in America. It does pay for some, but when Medicare cares about something, people listen. Medicare desegregated hospitals in this country. And so it is a powerful tool, and that's why I'm so excited about our birthing-friendly designation, because we are using the Medicare program to say we are going to look at hospitals who have agreed to enroll in quality initiatives for maternal and infant treatment and really judge that. And the private sector has embraced it. We've seen so many health plans also use our birthing-friendly designation, and we will continue to raise the bar. It's also a place of collaboration across the department. So HRSA and CDC are helping us with the hospitals and hospital systems that haven't gotten the designation to really give them TA, so that what our real goal is to make sure that everybody is getting the care that they need. And I think it's so important that we make sure, as we put in standards to improve care, that we make sure that all of the providers that are providing care have access to it. So those are two of our big pieces. Medicaid obviously has an outside role. We pay for 42% of births in this country. In some states, it's more than 50%, and we will continue to need to raise the bar. But I always feel it's important to say that the disparities are not just education and income. I can't tell you how many panels I've been on with women who look like me, who talk about their own experiences, who are highly educated, who have insurance, and we need to keep working to make sure that providers are listening to women, that we're picking up on the symptoms, that we are hearing and addressing these underlying conditions, which often are the result of missed symptoms.
Thank you all so much. And just a collective sigh to sort of let it wash over us of how much work is happening. And I think it's so clear how much passion each of you bring to the work from your own vantage point. And Chiquita, I want to pick up where you left off around that idea of, we're at a health equity conference. You can't have a conversation about maternal health without shining a spotlight on the disparities that exist in maternal health. So I'll take a minute to ask each of you a different question, but Chiquita, question for you. Can you tell us a bit more about your focus on addressing disparities, in particular in maternal health, and ending those disparities in maternal health outcomes?
Carole said something that I think is very prevalent sometimes in the way that we can operate, where CMS could be just the payer writing the check. And I think often people want to do the right thing, but they just assume, well, if you get people coverage, that will address disparities. And what I have tried to do at CMS, and I know all of their senior leadership, is to take a step back and say, we need to think about whether what we are doing is actually reaching all of the people that are covered by RMs and the providers that are covered, that are giving treatment to our underserved populations. And so that has been the lens that I have tried to help us bring at CMS. I think, we all know that there are several things going on when we think of the maternal health crisis. There are things that are people not getting access to services. There are not picking up on the symptoms. Hemorrhage is a huge one, and that's a big part of our birthing-friendly designation, of really trying to make sure that people are using some of the best practices. I also think, though, by elevating and making it a point of conversation, I don't know that 10 years ago people understood that we had such an issue of maternal mortality. I know it really wasn't on my radar of how great the gaps are in our country. And again, the gaps are true whether or not you have insurance, whether or not education. So I don't know if I answered your question.
100%. Miriam, I'll turn to you because you mentioned the release of the maternal mental health strategy and the task force and all of that work. Can you share for us a bit about the disparities that exist in maternal mental health and how you're working in that space?
Yeah, absolutely. And so there is a strategy within the report that specifically gets at racial equity, being trauma-informed, and ultimately working to address and eliminate disparities. And so we know, again, when we look at the data, that women of color are more likely to experience, adverse maternal mental health and maternal health outcomes. When we break that down even further, we find that African Americans and Latinos are more likely to experience challenges with postpartum depression. And so the report really gets at sort of looking at ways to really across the equity spectrum. We know women of color are particularly at risk, but other groups as well, women who are incarcerated, individuals that are part of military families, a whole range of other risk factors. So it looks across a range of risk factors and then sort of has recommendations for policymakers, for care settings in terms of ways, in terms of research, in terms of how to address some of those patterns and trends. So there's a whole series of recommendations around just the need to better understand, to do more research, to better understand what's driving some of the patterns and trends that we're seeing. and then to use that research to help inform policy, program development, and some of the other strategies that are being developed as well. In addition to research, is a whole series of recommendations around really paying attention to trauma and being trauma-informed, like really, really taking a trauma-informed approach in terms of assessments, in terms of how treatments are developed and implemented, and to make sure that that is addressed as part of the care process for individuals. And so there are other recommendations as well, but ultimately the goal is to have really an eye towards equity, to ask women about sort of their cultural beliefs or their preferences, and to have a greater understanding. So training is a whole area of recommendation, a whole area of work within the report as well. That, we need providers to have greater awareness of the range of cultural beliefs, values, and worldviews of individuals that may be accessing care, and then to incorporate that into the care process as well. And so those are just a few of the strategies, but ultimately the goal is to really meet women where they're at, also to work to address the social determinants. We know things like access to healthy food is going to make a difference in terms of a woman's overall health. Access to other community-based resources that impact housing, education. We can go across the full spectrum of social determinants, and all of those things can impact ultimately a woman's overall health and her child's overall health and wellness. And so the report gets at some of those areas. And so we're really excited about just the range of recommendations. And, we have a call to action for everybody. Take a look at it. Help us to disseminate the report. It really is quite rich, and I think can serve as a real valuable blueprint for getting at the range of disparities that we are seeing, unfortunately, across the board for, women from diverse backgrounds.
Thank you. In hearing all of you, the theme that's resonating in my mind is this idea of we just need to listen to people and not assume that because of where they live or what they look like that we know what they need. And so, Carole, question for you. Through HRSA's Enhancing Maternal Health Initiative, you all, I think, have done a lot of work around centering lived experience, and I wonder if you could say a few words about that.
Thanks so much for that. We this year launched our Enhancing Maternal Health Initiative, where I just talked a little bit about all the types of things that we fund through HRSA. And so what we've done is go to states and say, bring all those grantees together and say, how do we make the sum greater than the parts? And how do we really leverage all of our grantees to expand access to the hotline? How do we make sure the workforce we're training is filling workforce gaps in some of our service delivery sites? But because we firmly believe that this work needs to be centered around and listen to the voices of women, we begin every session with women with a lived experience. And it is eye-opening and heartbreaking and all the things that you would expect it to be, but even more. But there are always these amazing stories as well as to how the funded entities that we support are in the community at the other end of the phone at 2 a.m. or 2 p.m. and will drive over and help you with X, that it makes such a difference when there's someone to call and it's someone you trust, and often it's someone from your community and it's someone who's had an experience like you. And that's why it's so important that we're investing our dollars in training more OBs. It's absolutely important that we're doing that. But we've got to be investing in more doulas and more community health workers and more and creating career ladders for people from the community to be in this work with us together. And we do that. We are, one of our panels at these sessions, we had a woman who is now a home visitor in our home visiting program. But she told the story of how she came to that job by having been in crisis herself and seen a flyer at the laundromat or the community center or the library or somewhere and taking the number off of it and calling and getting home visiting services herself. And those are the kinds of stories that both make this work meaningful, but also are just a fraction of what we need to do.
Thank you. Thank you all again. Last question. As we think about the theme for this year's conference is really about sustaining health equity through action. So, Miriam, I'll start with you and then we'll go down the line. Looking ahead to the future, what are you most optimistic about?
I'm definitely optimistic about, for one, the fact that we do have a blueprint now through the national strategy that can really serve as sort of a guidepost around how to take a multidimensional, multi-system approach to be able to address sort of maternal mental health and help women and communities to thrive. The other thing that, related to that is I just love the level of sort of collaboration and the level of, we have folks participating across psychiatry, research, psychology, community members, many women with lived experience who have been right there sharing their experiences and helping to inform the various strategies and approaches that are in the report and in the national strategy itself. So that's heartening to me, the fact that, we have this blueprint and folks across the country that are really leaning in on this important, really critical area in terms of helping to reduce maternal mortality and paying attention to the mental health component of that. One last resource I will mention is our 988 Suicide Crisis Lifeline. I'm optimistic there as well because in less than a year and a half, about 9.6 million calls, texts, and chats that have come in. And so that is available also for women that are in any form of mental health, substance use, or suicide-related crisis. And we know that is an area that has contributed to some of the maternal mortality patterns that we see. So I'm optimistic that there are resources and that there is work and opportunity for women to engage and get connected to the needed services and supports that are available.
Thank you. Carole?
Well, I'm optimistic because this room is jam-packed. Like, this is the work, and you are the people doing the work. B, I'm so incredibly optimistic because from day one, the president and vice president have said this is unacceptable, and we need to do different and we need to do better. And since that time, all of the work that you've heard here today and so much more has been happening across the administration. Chiquita mentioned the vice president's leadership. She and I had the opportunity to go to the first ever cabinet meeting focused on maternal health, where we as healthcare folks sat next to the Secretary of Labor and the Secretary of Housing while the vice president said, how are we going to do this together? And how do we think about what we all in the policy world call social determinants of health and other people call like what you need to be healthy? And finally, I'm so optimistic because in addition to the work that I talked about, we also have the privilege at HRSA of funding what we call state maternal health innovation task forces. And so this is with the help of the Congressional Maternal Health Caucus, we've been able to launch these task forces around the country that are doing incredible work, really thinking about how to meet local needs in their communities and how to build a plan that looks like our blueprint at the state and local level. So I think my big optimism is this administration has the back of people who've been doing this work for a long time, and together we're going to make a huge difference.
Thank you.
So Miriam and Carole captured so much of what I would also say is exciting. The only other thing I would add is I'm excited because I think there's just a different awareness and a different level of we need to fix this, which I think is what you need to do to move the healthcare system in this country. And there is so much more focus and a spotlight on maternal health and health equity more broadly. And I think we have a tremendous moment and an administration that is not going to accept it and is so committed to making sure that we move the needle on, again, maternal health and other items that I think we will seize this moment and move to a better America.
Thank you so much. I really can't imagine a better way to end, but Chiquita, any closing comments as we wrap the session?
Okay, well, just again, I hope everyone really enjoys being in community together over the next 2 days. And just a huge thank you to my colleagues for joining me, not just on this panel, but much more importantly, on trying to work together so that we're not all working in silos to try to address this maternal health crisis. Because I think, as we all know, just coordinating our efforts is so key to moving the needle on so many issues. So thank you.
Thank you. Thank you.
Well, thank you to Aditi for your work and for leading the office and for all the contributions you've made to the field. I am so fortunate to have these incredible colleagues. They make our work better every day. And I just want to say thank you to everyone who's here and those who are at home filling in for you while you're here, because we know that when you do this, there's so much opportunity to learn from each other, and as a community is so incredible, but it's a sacrifice to be here, to be away from your work and your clients and the people you serve. And we're grateful that you figured out a way to do it, because we know when you'll go back, you'll continue to be driving this work in communities across the country. So thank you, and thank you for the work you do every day.
Yeah. And, I just want to echo that as well. I mean, I just so appreciate that again, that the room is packed. Others have mentioned that. And, the work that you do every day, day in and day out, to make a difference in the lives of women and families that need support and that need care. So I thank you all for that, and thank you for being here. I thank you for all the work that I know that will be happening in terms of moving forward the national strategy together. I often say I'm a clinical community psychologist by training, and I often say, it takes a village. It takes a village to sort of move and to do important work together. And so I'm grateful that we can all be part of that village together to make a meaningful difference in the lives of women that are needing support and needing care. So thank you.
Thanks, Dean.
I have a couple housekeeping things, and then we'll do one more round of applause. Okay. But for our audience, we'll now move to a short break before we begin our first set of breakout sessions for the day. There's an agenda online, and for those joining virtually, all the breakout sessions are available. For those in person, if you flip over your badge, if you haven't already done this, ta-da, there's a QR code there. The QR code on that badge will take you to the conference website to help you navigate the particular room for the breakout session that you might be looking for. There's signs, maps, and friendly faces that are happy to help you find wherever you're trying to go. I'd encourage you to please check out the Federal Partners exhibits as well as our posters. Those are available for in-person and virtual attendance. Lots of resources and information about health equity projects happening across HHS and across the healthcare system. We will look forward to seeing you back here in this room at 1 o'clock for the afternoon keynote. With that, my deep and sincere gratitude to the three of you for not just being here today, but for your tremendous leadership. A joy to share the stage with you. Thank you again.